Welcome everyone to our Circle seminar, which is on how do you reform social care, reversing drift in the 4 nations in the UK. I'm delighted that we have so many of you with us today, and some of you from overseas and some of you from within the sector and outside academia. So very warm welcome to all of you who have joined this session. Patrick and Catherine are both members of the Sustainable Care team and have been leading the work that Sustainable Care has been doing on comparing the adult social care systems of the 4 UK nations. And I'm very, very pleased that we have an opportunity to hear what they have to say today. My name is Sue Yendall. I'm the Director of the Sustainable Care Programme and of Circle at the University of Sheffield. Catherine Needham is Professor of Public Policy and Public Management at the University of Birmingham in the Health Services Management Centre. She has her PhD from Nuffield College, Oxford, and she has published widely on social care, many articles and some books as well. And most recently, she published an article on self-funders in social care, in social policy and society, as well as an article in the BMJ on the issues arising from the neglect of adult social care in the COVID-19 crisis. Patrick Hall, working with Catherine on our 4 nations comparison, is based primarily at the University of Birmingham, but also has an affiliation with the University of Sheffield. Patrick was formerly at the King's Fund, where he was a contributor to the important publication on social care for older people, Home Truths, in, I believe, about 2016, probably just before you joined us, Patrick. So a very warm welcome to them both. I believe Patrick's going to speak first, and then Catherine will come in after his opening comments. So over to you, Patrick.
Thank you very much, Sue. And yeah, a huge thanks to Kelly and the rest of the Sustainable Care team that have made today possible, and to everyone that's attending, because I think it's a really good turnout. And yeah, hello to colleagues from around the UK and wider. It's really good to see everyone here together on this important matter. So in this presentation, we're going to use the concept of policy drift to explain the perceived lack of progress on adult social care funding reform in the UK, and in particular we compare the 4 nations of the UK, each of which has its own care system and has made differential progress on care reform. We've seen recently in the development of conservative policy on adult social care funding a kind of classic example of what we'd call policy drift, and we really think that English funding reform over the past few iterations of government really does exemplify this concept. So you can see within Boris Johnson's term, promising to fix the crisis once and for all, this kind of big bang vision, we'll get it all done, all once and for all. Then a kind of scaled back promise of proposals, and within a week of promising scaled back proposals within the Queen's speech, we seen that in fact there won't be much detail at all, and that the intervention of the Treasury was a key factor in preventing that, acting as a key veto player, which we'll come on to describe. So we argue that England's social care funding reform is a classic example of this drift, and that the 3 other administrations in the UK have diverged in various ways from this drift, and that divergence tells us something interesting about how we might all move forward on this conversation, at least to open up a different type of conversation to the one that we seem to be continually having. So it's no surprise that when we started this project, it was really driven by this perceived crisis, the crisis narrative that pervades social care debate in the United Kingdom, intensified by the COVID-19 pandemic and its devastating impact on care homes and disproportionate impact on older people in particular. I think for us, we want to contextualize this idea of crisis as driven by a perceived social failure to care for older and disabled people, and should be understood in the wider context of new social risks that are associated with contemporary late modernity. So the aging society, downward trends in fertility and mortality, expected age-related disability increases, changes in family and working lives, and the ongoing existence of a means and needs tested system established post-war, which is perceived now as unfair, particularly alongside the NHS as a free at the point of access system. But the interesting thing, I think, about this crisis is that it never seems to come to an end. Normally a crisis is a point at time where you need to make a decision, someone needs to do something, and things need to change. But that's, for us, the crisis narrative really misses something key. So I think that's when we started looking at the context of this, to think about, actually it's not that nothing's changed, it's that the context is massively changing all the time. So the care crisis in the UK is portrayed as an example of a reform deficit, so a long-awaited and much-needed reform that hasn't been delivered. In particular, this perspective refers to the failure to identify a sustainable funding model for social care that responds to demographic change and increased demand. So what's drift? We characterize social care funding as an example of drift. Drift examines why policies do not change, even when there seems to be widespread agreement within policymaking communities that there should be a change, a significant change, and there has been a significant change in the social risks that they were originally designed to solve. So, the formal policy remains the same, and yet this context is radically changing. And a second important aspect of policy drift is that it's a deliberate action. It comes about as the consequence of policy actors' agency and choices. It requires that potential reform solutions are available, but deliberately not adopted by those policy communities. And that doesn't mean that there's some kind of collective choice to not adopt change, but that there are key actors often working within those policy communities that prevent them from happening. So in order to operationalize this concept, Rocco distills 4 causes of drift: cost, automaticity, that's always a bit of a mouthful, so I'm glad I got through that, veto players, and partisan polarization. Other literature has added additional factors, including uncertain policy outcomes and feedback effects that make changes politically risky, in addition to policymakers' limited attention span, or that there's a crowded agenda capacity, or that there's some kind of limited time or powers. So we synthesize all of these factors together. So cost, is it expensive? Automaticity, will change happen without intervention? 3, veto players, can any reform be potentially easily blocked? Partisan polarization, so is it a divisive party political issue? Uncertain outcomes and complexity, so is there a clear way forward with predictable outcomes? And finally, agenda capacity, so do policymakers have time, and in our case, do they have the legislative power to address the issue? of course, when we're comparing different aspects of this problem in the UK, we've got to be really cautious about making claims about the different systems. Of course, the units are not equally sized. England has by far the largest population, around, and followed by Scotland, Wales, and then Northern Ireland. And Northern Ireland has a really distinctive health and care set of institutions created in the 1970s, reflecting the political violence that reshaped the institutions there. And the other three nations operated under roughly the same care system until 1998. Importantly, England has no devolution settlement, and hence no opportunity to develop its own, I suppose, its own distinct policy community. So the decisions made about adult social care funding reform are locked into the Westminster system, into the Whitehall system, and that's really important when we're considering drift. Right. So address drift. So to address drift and move social care to a more sustainable funding model, we looked at documents from all four nations, and they highlight the need to change the funding model. And this can relate to how monies for care are collected and how they're allocated. So collection refers to, whether money comes into the system through general taxation, social insurance, private insurance, user charging, and so on. And allocation refers to how that money is spent, who is eligible, is it means tested, is it free at the point of access, under what conditions, and who gets these new resources that have been collected. And obviously these elements are closely related and can be dealt with as in a single policy intervention. They can also be separated out, and often are separated out in reality. The jurisdiction of the devolved nations are such that they might be able to make amendments to care allocation, so whether it's means tested or not, at the level of the means test, or whether it's free personal care. But whether they can reform the collection of resources, so raising money through general taxation or other means, it varies by jurisdiction and shifts over time as each polity receives more powers. So, we've got to be careful when we make these comparisons to try and understand the different institutional dynamics at play. Catherine?
Fantastic. Thanks, Patrick. I'm just going to go back a slide if I can. Yeah, there we go. So yeah, I just wanted to say something about our methods then before we get on to reporting our findings. So we interviewed who we called key stakeholders in the four nations of the UK. So people who were either working within the governments, who were working in key organisations in the care sector. So that was not-for-profit and the for-profit sector, and then other organisations like Carers Northern Ireland, Carers Wales, and other kind of key sector bodies, to get a sense of kind of what they saw as some of the key dynamics around social care reform in the four polities. Within the governments, we spoke to civil servants and we also spoke to politicians. Alongside that, then, we had the analysis of key policy documents. So when we were interviewing people, we asked them about what they saw as the key kind of foundational documents over the last 20 years since the 1998 devolution settlements, what they saw as the kind of the key policy documents that had steered change or that had proposed key changes. And those were the documents that we analysed in terms of looking for what was the kind of intent. I think what was really striking about all of those documents was how much they used the language of reform being overdue and urgent, and that it needed to be reformed for a new kind of generation, and yet how rarely much of the things in those documents had actually happened. So I guess that was what kind of got us interested in this concept of drift. And what was evident in those documents, there were sort of two main forms of drift correction if we focus just on the sort of funding side of care, and that's obviously only one aspect of care reform. So there were sort of two main kind of sets of reforms on the agenda around funding. So the first would be to bring social care into alignment with how the NHS is funded, and then the second would be the sort of what we call the sort of deal not proposals around introducing a cap, so continuing private payments for care for people above the means test threshold, but capping the individual contribution to limit the liability, so a sort of more moderate form of reform. And what's interesting is we can see kind of versions of both of these types of drift corrections, we call them, have had some success in becoming policy over the period. So if we move on then to look at each of the four in turn. So it was the Dilnot Commission around 2010 that proposed, that was the sort of key intervention around proposing a cap on private care costs within the care system, and that was a kind of a key intervention, and that was brought into law in England in the Care Act 2014. So it's kind of seemed to be having its heyday as a proposal. There seemed to be a lot of political support for it. But what was striking about that was, despite being contained in legislation, it was that part of the Act was then postponed because of perceived problems around implementation and austerity in the sector, and then effectively came to be abandoned with the suggestion that something would be coming forward in its place, which has never yet come. Interestingly, we see the same thing in Wales with the Social Services and Wellbeing Act. There was a cap along the same model in that Act, and again it was postponed in line with England, and has never come back in that form. But we have seen some more, what we'd call more progress on drift correction in Wales, because although they haven't done anything around the cap in that kind of broader, more ambitious version, we have seen the introduction of a maximum charge for home care, so maximum weekly amount that people will pay, and also an increase in the means test threshold. So the English means test threshold is still stuck at £23,250, which has been that since I think it's about 2010, whereas the means test threshold for free care in Wales is now at £40,000 for residential settings, so it's gone up significantly compared to England. So we have in that sense seen more progress in Wales. So Scotland opted for the alternative of those kind of two models we had, of the kind of the cap model versus the kind of try to align it more with the NHS around a free provision of care. So Scotland opted for free personal care as proposed by the Sutherland Commission, which was around the turn of the century. It was Sutherland proposals of free personal care were rejected for England and Wales as too expensive, but they were brought in for Scotland. Scotland brought it in at first for people over 65 and more recently for younger disabled people. So if you have personal care, there's no charge for that care. So important to be clear that that's only certain parts of care. So if it's involving support with washing and dressing and access to food, some of those activities of daily living, but there is still a charge for things like aids and adaptation, for transport, for Meals on Wheels. So it isn't. So there's only certain things that are contained within that. But nonetheless, it constitutes, I think, quite a significant step forward compared to what we've got, certainly in England. Northern Ireland is different again, partly because of a very different starting point. So I think progress on care reform in Northern Ireland has been hampered by the broader lack of legislative activity over this 20-year period since 1998. In large part because of long periods of suspension of the executive, including until very recently, so 2017 to 2020, which means that Northern Ireland hasn't had the equivalent of the English or the Welsh Care Acts, still doesn't have a kind of legislative basis for carers' rights, for example. So there's a sort of issues around care reform and legislation, but then there's also the added factor that Northern Ireland has a much more structurally integrated health and social care system than is the case in other parts of the UK. I know they're kind of trying to move in that direction, but Northern Ireland is much further forward and has had that since the 1970s. And that presents a kind of quite an interesting paradox, because due to the integration with health, and health isn't means tested there as it isn't elsewhere in the UK, there currently isn't any charge for personal care at home. So there is effectively a sort of de facto free personal care in Northern Ireland, although there is a means test for residential care, which is set at the same rate as England. And it's kind of quite interesting, I think, that one of the key policy proposals around reforming and updating social care in Northern Ireland, the Power to the People report in 2017 was actually proposing the introduction of means-tested domiciliary care, so moving away from the free personal care model. And I think that's sort of fascinating, given that the kind of mainland UK has been working quite hard, and lots of people advocating quite hard for free personal care. They got there in Scotland, and that Northern Ireland is sort of seeing the limits of free personal care, because it means that people who can afford to pay don't have to pay, and is saying that the kind of future of social care may be better thought of around means testing. So there are sort of different places, but in a way they're also kind of going in different directions. So in terms of analysing the data that we had from the interviews and the documents, we then analysed it alongside these criteria that we'd got from the literature on drift, to see kind of which drift elements were evident in the 4 settings. And I think what's quite evident here is that England basically has all of them. It has all of the reasons why care reform is difficult, whereas in the others we don't see quite such a concentration of factors to make it difficult. So if we start with cost, we can see that austerity has been a particularly major barrier, I think, in care reform in England and Wales, but that Scotland hasn't had the same kind of austerity, nor has Northern Ireland, if you look around the patterns in care spending. Around automaticity, so this is the notion that reform will that change will happen without intervention. Then we have seen some of that in Northern Ireland because of the integration with health, which means if there's an uplift for health, as there usually is, then social care gets the benefit of that, whereas we don't have that in England, Scotland and Wales, so there is no kind of automatic uplifting. The issue of veto players is interesting. So this is about whether either within government, so say the Treasury, or external to government, say the Local Government Association, whether there's a kind of key sectoral players which are proving to be a block on drift. And we found in our interviews that those sorts of factors were talked about much more in England and Northern Ireland than they were in Scotland and Wales. So in Scotland and Wales, we got a sense much more that the governments felt able to bring forward the reforms that they wanted. In terms of veto players, I think Patrick's already mentioned the Treasury, and would see them as having a key role around blocking various iterations of funding reform. But I think that's what's also kind of interesting, and what we're playing with in our analysis and write-up is that as well as some people blocking reform because they don't want reform to happen, they think it's too expensive, I think we've also seen blockages from people who think it's the wrong reform, or it doesn't go far enough, or we need to do more. So there's sort of, I think in a way there's a bit of a pincer movement, I guess, between the people who think you've done too much and the people who don't think you've done enough, and together they can play a role in unsettling or undermining attempts at reform. Political partisanship and the sort of polarisation of the debate came up in the English interviews. So clearly we've had some very toxic election campaigns around social care issues, death tax, dementia tax, etc. So that seems to be a clear issue in England, the lack of any kind of cross-party consensus. In Northern Ireland, the feeling was not so much that social care itself was a politically contentious issue, because in a way it's been moved into health, partly to kind of get it out of the political sphere, but that the political debate continues to be defined by what one interviewee described as the sort of the orange and green debates between policies, and the sort of the fragility of that political settlement, and that gets in the way of progress. I think in all of the countries we can see evidence of uncertain outcomes. So partly where you've got a reform where it's not necessarily clear that, there's a huge amount of complexity. We know this we saw this in COVID, around the sector is so complex, the delivery chains are so complex because of the huge fragmentation of delivery, that it can be difficult to understand if you kind of pull a lever in Westminster and Whitehall or Cardiff or Belfast or Edinburgh, exactly what will happen to this fragmented sector. So I think we see all of them are kind of a bit wary about making progress on reform. And in terms of agenda capacity, we've also seen limits there, apart from in Scotland, where the sense we got was that they have been able to pursue the reforms they wanted. England has been very distracted by Brexit. Wales has been very distracted by institutional formation, because it got a very of lightweight devolution settlement in 1998, and it's had to gradually build its institutions up, which Scotland hasn't had to do to the same degree. So that's been a kind of a limit on capacity. And then in Northern Ireland, we've got the suspension of the executive. We've had the kind of pressures of Brexit there as well, and the role of the DUP in upholding Theresa May's government. So there's been a number of different issues there which have affected agenda capacity around social care reform. So in terms of some of the things that people were saying to us in the interviews, we can see in Northern Ireland, I guess this is a quote which highlights some of the things I've mentioned around, firstly, that sense of kind of the civil service are having to kind of get on with things in the absence of a legislative steer, and that brings in some of that automaticity, but that's kind of problematic in that there are limits to that because you can't make legislative change on that basis. And then there's the point about the kind of the particular kind of political sectarian complexion of kind of the Northern Irish context, which makes drift potentially more of an issue there. In terms of Wales, I think things that have been emphasised there is partly the relative newness of the institutions and the sense of a lot of energy has gone into institution building, clearly the distraction of COVID there as well as elsewhere. And then this sense of a kind of somewhat competitiveness over austerity, and a sense that Scotland has done much better out of devolution and indeed pre-devolution because of the way the Barnett formula through which allocations to the different polities are defined, that Scotland does better and hasn't had to cope with the same level of austerity as Wales. In Scotland, I think some of the debate is really about whether free personal care has worked. So they've got the policy, it's been implemented, but there is some sense that it's caused greater rationing because obviously it still remains a scarce service. The kind of the structural limits on delivery in Scotland are pretty much the same as elsewhere. So insufficient staffing, pressures on downward pressures on quality, and a sense of kind of not enough capacity in the sector to meet the growing need. So there are kind of issues there around, whether we've kind of seen the implementation of what feels like free personal care, and the sense of potentially shrinking eligibility as a result. And then in England, this sense of the kind of the role of the Treasury, which I think, as Patrick flagged at the beginning, is sort of raised its head again around the Queen's speech just last week. That if you're developing the Care Act, which this quote refers to, got many years worth of development through the Law Commission. It was seen as a very important and very well supported piece of legislation, but that maybe the Treasury weren't so engaged, and so when kind of money conversation was really acute around the care cap, that there just wasn't the sense of a kind of willingness and ability to deliver on that. So hopefully highlighted there some of the kind of factors that have created this sense of sort of differential drift in the four parts of the UK. What we can do is kind of map these then onto, I'll put the slide up and then I'll explain it. This 2x2 matrix, which we've got from Hacker's work on drift, which we found really useful. So Hacker says there are some places where it's really hard to get kind of policy to change, and then there's some places where you might not be able to get the policy to change, but you can actually sort of convert within it. And so what Hacker's work brings is saying, rather than having just drift, top left, or just revision, bottom right, you can have these two variants, one of which is conversion, so kind of making change within the existing legislation, and then the other of which is layering, where you've still got the original legislation, but you put new legislation on top of it. So so you start to kind of make change that way, rather than, it's not quite the same as full revision, but you're actually kind of making progress. And so as our flag pictures illustrate, we would put England very firmly in the top left. Very difficult to sort of say there's been much progress on care funding reform in England. It's constantly talked about and yet never done. We'd suggest that Northern Ireland has done some kind of conversion because of the scope within it being embedded within health, they have been able to do certain things around care, but there is still, I think, a sense of frustration there that they haven't been able to move things on in a legislative sense. So it's been a kind of somewhat minor. And then we would see Scotland and Wales as both kind of having different levels of layering. So although neither of those have effectively brought any more money into the system, we're still operating on the same kind of way of raising funds for care in both of those. They have made changes in the allocation of care, and that's particularly the case in Scotland, where we would say through their free personal care, we've had, I guess we'd say, sort of major layering. In Wales, we've got a kind of minor layering through the cap on weekly spending and the rise in the means test. So that's kind of why we think it's kind of useful to kind of bring them out in those different sorts of boxes. Okay, so to finish with some thoughts for discussion, we would say that clearly there are some issues of institutional design at work here, which are very much relevant to the drift debate. So we would say that Scotland, which had the most kind of advanced version of devolution and has had it for longest, has gone furthest on care reform. Wales has had to put a lot of energy into institution building. Northern Ireland has had a kind of back and forth around the suspensions and that very kind of fragmented period over the 20 years that we're looking at. England and Westminster remain stuck, and we have this very asymmetric devolution where England is still governed by Westminster with its kind of large departments, lack of kind of access often for other kind of key stakeholders, so it just doesn't have that sense of a kind of open executive and legislature that we got from our Scotland and Wales, and to an extent Northern Ireland interviews as well. Some interesting work from Keating around territorial policy communities, and Keating highlights that as well as the kind of institutional factors around design, etc., there's also issues around kind of shared cognitive frames and the extent to which we find that, we find kind of expression of that. And we did sort of, I think we would argue that we did find that there was a sense of kind of shared endeavour perhaps between the key stakeholders in Cardiff and Belfast and Edinburgh that there wasn't in London, where we found a more sense of the sort of adversarial relationships between the key stakeholders, and also a sense, I guess what we've called here performative elements, that Scotland in particular was very keen to emphasise how far it had gone, its distance from Westminster and England, and that it had kind of seized this agenda. And that Wales too was keen to separate itself off from England, and to look to Scotland as being the kind of leader in this area and something that it tried to equate to, tried to sort of move towards. I think what's interesting about drift is that it's not necessarily lack of action, because we've seen, I think, a lot of policy activity, civil service activity in all four of the nations around care. And I think in England, we've, although no progress, we have seen these kind of I think a lot of work's gone on within the Department of Health and Social Care around reform options. It's just that we never quite seem to get beyond that conversation, because it always gets stuck at that point of moving it into formal policy change. And I think it's important to emphasise as well that the kind of, we could call it a sort of incrementalism, the sort of layering, the conversion, isn't quite the same as we've seen in other countries that have taken an incremental approach to the care reform, like Germany and Japan, where there's a much stronger sense that this is they're on a road somewhere and they've got that clearly mapped out, and they're doing it in a staged way, and I think that can be beneficial. But that's that's not necessarily, I think, what we're seeing here in terms of reform. I guess the question that we're grappling with, and it would be interesting to know what kind of people think of it, is whether the kind of I mean, tinkering is a bit unfair. It's more than tinkering. Whether the kind of work that's been done in Scotland and to some extent in Wales and Northern Ireland to add things onto or to adapt within an unsatisfactory system is helpful, or whether it's better to almost be in the English position where things are so bad that you actually need a kind of proper full revision, a new beverage, a new kind of radical conversation about what does it mean that we care for each other, and that we have a kind of population, which means that kind of care needs to be thought of differently. So do you weaken the momentum for change by kind of layering and adapting, or do you actually build it? I think that's a question we're kind of thinking through. And then just finally, I guess this sense that England left that the kind of the once and for all, that was wording from Jeremy Hunt, who was former health secretary, who said we need a once and for all solution, but thinking perhaps tactically that isn't the right way to go, because when you've got a once and for all, you've got to try and solve everything in one go. You make this bigger target for players of different kinds, and also you build fatalism when it fails. It feels like we've kind of attempted to get there so often in England, it's failed, that people, me included, sometimes think, you know, can we ever make progress here in what feels like a dysfunctional policy space? So we'll leave it there. Thank you.